Yeah, I'm sorry for the. Okay. So we were just talking about spontaneous non-traumatic intracerebral hemorrhage. Is a significant cause of mortality and morbidity, excellent medical care, and the overall aggressiveness of ICH care is directly related to the mortality of the disease. It occurs because of rupture of a blood vessel in the brain, accounts for 10 to 15% of all cerebrovascular accidents, 2 million strokes worldwide, rise of admission in the past 10 years by 18%, and prognosis is poor as estimated mortality is 30% at 7 days and about 90% at 16 years. Now we all know that the causes of ICH are hypertension, vascular valve formation, tumors, bleeding diastasis, amyloid angiopathy, hemorrhagic infarcts, and trauma. The clinical features are all well known to you: headache, vomiting. Is it a metabolic penumbra in intracerebral hemorrhage? So we're talking about a metabolic penumbra because of a hyperperfusion penumbra. Now this was very nicely worked up in the perihematoma mitochondrial dysfunction after intracerebral hematoma. They did the PET and oxygen extraction fraction imaging in ICH, which show no increase in the OF in the perihematomal zone. Nonetheless, the surrounding tissue displayed reduction in oxidative metabolism with very low rates of oxygen use. So the whole concept of a penumbra was different from the concept of a penumbra which we talk about in an infarct. And this is more of a hypermetabolism leading to some amount of hyperperfusion rather than anything else. This reduction in oxygen use is thought to be attributable to impaired mitochondrial dysfunction, which has been confirmed in tissue samples during surgery in patients with brain hemorrhages. The impairment of mitochondrial function implies that the metabolic crisis is occurring in this tissue despite the absence of brain ischemia. Sorry. Okay. Now, what are the principles of ICH management? Dr. Shivakumar has talked about certain aspects, which I will not go through it again. Of course, you have the ABC, blood pressure, acute hemostatic treatment, anticoagulation reversal, intracranial pressure control, and monitoring. The most important thing in ICH is the management of blood pressure. And we, with the help of our critical care colleagues, are more interested to know and should know how should you manage ICH hypertension in a critical care unit. BP is elevated in admission in patients who have no history of hypertension, and the mean arterial pressure would be very, very high. It could be a precipient of a hemorrhage. It could be a reflection of chronic hypertension. It could be attempt to maintain the cerebral perfusion pressure. It may be a symptomatic activation to pain or anxiety and tends to return to normal 7 to 10 days after ICH. So, the response of hypertension in a patient of intracerebral hemorrhage is related to so many factors. Now, you just saw this, that the cerebral perfusion pressure, the cerebral autoregulation curve, which means the cerebral perfusion pressure depends upon the mean arterial pressure and the ICP. So what is the acute management of blood pressure? Presumed cause of hemorrhage is, we are presuming, it's hypertension. How fast should BP be lowered? Rapidly lowering mean arterial pressure 15% or less does not lower cerebral blood flow. But reduction of more than 20% can affect the cerebral blood flow. Current guidelines suggest a reduction of 20% or so in the first 24 hours, and which agent should be used depends on what you're used to using, labetalol, hydralazine, and nicardipine. But my request to our critical care colleagues is not to use sodium nitroprusside, nitroglycerin, because it causes vasodilatation and it has got a potential effect on the ICP. Now, when we talk about hypertension, we got a large number of trials. We want to really look, should we maintain the blood pressure at the standard level, or should we bring the blood pressure very fast? So this was the first trial, which was called the ATTACH-1. The ATTACH-1 was the anti-hypertensive treatment for acute cerebral hemorrhage. This trial had only 60 patients, so obviously you have to take this trial with a pinch of salt. It was to determine the tolerability of the treatment. 3 different systolic blood pressure goals were seen. Intravenous nicardipine was used for 18 to 24 hours post-ictus. Subject with ICH who present within 6 hours of the onset. To define the goals of 3 escalating systolic blood pressure, the rate of neurological deterioration, and serious adverse effect using intravenous nicardipine. So what did they do? If you see ATTACH-1, they had 3 goals: 170 to 120, 140 to 70, and 110 to 140, which would mean that do you want to have a blood pressure below 140? You want to have a blood pressure below 180, which is the standard thing which we talk about. What did they find? The underlying mechanism for the expected beneficial effects of intensive cerebral SAB treatment is through a reduction in the rate of magnitude of the hematoma, expansion observed in approximately 73% of patients of ICH. Data from ATTACH trial and also from INTERACT trial showed that the reduction of hematoma volume expansion with more intensive and early lowering was likely. But these results indicated that you required further research, because what you were doing was you were having very, very small number of patients, which was only 60. So you couldn't make any conclusions on what exactly you should do and how should you monitor the blood pressure in an intracerebral hemorrhage. So then this trial came, very interesting trial, that was INTERACT-2, which came in June of 2013. Does rapid lowering of blood pressure in patients with acute intracerebral hemorrhage helps? This was a randomly assigned trial of 2839 patients who had a spontaneous intracerebral hemorrhage within previous 6 hours and who had elevated systolic blood pressure to receive intensive treatment to lower the blood pressure with a target systolic of less than 140 within 1 hour, or the guidelines recommended. We are talking about less than 140, and the guidelines recommended with a target systolic of more than 180. So they were comparing rapidly bringing down to conventionally what you and I all do with the use of agents of physician's choice. So they say you could use anything. You could use nicardipine, you could use, except for your sodium nitroprusside, you could use anything. You could use your labetalol, depends on what you are used to and what is available in your hospital. So what are the conclusions? What were the conclusions of INTERACT-2? Very important conclusion. In patients with intracerebral hemorrhages, intensive lowering of blood pressure did not result in a significant reduction in the rate of primary outcome of death and severe disability. So primary outcome was death and severe disability. But when you brought the blood pressure suddenly, it did not make any significant difference. But when you did the analysis on a modified Rankin score, there was improved functional outcome with lowering of blood pressure. So you could take it the way you wanted. You did nothing in the primary endpoints, but you definitely showed improvement in the modified Rankin scale at the end of 3 months. Still, they were not satisfied. Then we got the trial called ATTACH-2, which is a very recent one in September of 2016. Again, does intervalling loading blood pressure help in patients of intracerebral hemorrhage? This trial again took about 1,000 patients with intracerebral hemorrhages, volume less than 60, and a Glasgow scale of 5, to a target of 110 to 139 intensive treatment again, and a target of 140 to 179 standard treatment in order to test the superiority of intensive reduction of blood pressure. So what did they find again? Now, I won't go into this trial, total trial, but the inclusion criteria were 18 years or older, we just talked about, and exclusion were that they did not take patients who had neoplasms. Very interestingly, this was a study flow which they did ATTACH-2. What did they do? They got patients with symptoms who arrived in the ED. The patients were screened by the ED staff, failed screening, screening passed, randomized 1:1. Okay. Standard treatment, intensive treatment. So they randomized the patient 1:1. These guys received the standard treatment, these guys received the intensive treatment. 24-hour CT scanner, Beck's medical treatment, and day 90, they did the blindest MRI and assessment on the European scale. Now, what did they find? Now, this was the nicardipine used. As I said, it doesn't matter what you use, but they use nicardipine. Now, the treatment of participants with intracerebral hemorrhage to achieve a target blood pressure of 110 to 1 did not result in a lower rate of disability than standard reduction of what we talked about. So ATTACH-2 did not find same thing what they found in INTRACT-1, but I don't know why ATTACH-2 didn't talk about the modified Rankin scale at the end of 3 months. But they did not find any significant difference between the standard treatment and aggressive management of that. So now you can make up your mind. And when you go out of this, you would ask me, what is the message do we go out of it? We were talking about INTRACT-1, INTRACT-2, ATTACH-1, ATTACH-2. What should we do in a clinical setting? And I think in my own experience, and in my own review of what I've been doing over a period of the last 20 years, is that intracerebral hemorrhage does require intensive blood pressure management to bring down the blood pressure as early as possible, because it decreases the mortality, morbidity, and also helps to decrease the hematoma expansion, which is a major cause of mortality and morbidity. Now, here is a slide to show you what is a hematoma expansion. We all talk about hematoma expansion. You see the hematoma volume, time from the onset, and you see the final volume. And this is exactly what you see if you do your CTs more often. What are the risk factors? Are there any factors which will say that this guy is going to expand for early, this guy is not? Early clinical presentation, spot sign, which I would come to a little, larger initial hemorrhages, warfarin people, large intraventricular volumes, heterogeneity of hematomas. What I mean by heterogeneity of hematoma, in the same hematoma, you find various stages of blood. That's a heterogeneous hematoma. Elevated D dimers and reduced platelet activity. So if somebody asks you, if the patient wants to know, these are the things which you would think could lead to hematoma expansion. Several risk factors are associated with the worst outcome of hematoma expansion. A large hematoma volume in presentation, early presentation within 3 hours, high risk because it undergoes tomography, and for those on warfarin. So these are the risk factors associated. Now you can just see for yourself. This is a CD picture of a brain scan from an acute intracerebral hematoma, 1.5 hours and 4.5 hours that the hematoma has significantly expansion. Now, Now, what is a spot sign? I mean, anybody who is going to look after intracerebral hemorrhages, please remember that you should know what is a spot sign, what is a swirl sign. These are the basic clinical things which would tell you. Now, what is a spot sign? A spot sign is a focal area of enhancement within the hematoma on CT angiography and has been shown to be an independent predictor of hematoma expansion. Associated with large median hospital stay, independent of time of presentation, sometimes sensitivity 91% and specificity is 89% for this spot sign. Now this is what it looks a spot sign looks like. It is a focal area of enhancement. It's a focal area of enhancement within the hematoma and has been shown to be an independent predictor The recent proposal of a spot sign definition is a serpentinous or a spot-like appearance within the margins of a parenchymal hematoma without connection to the outside vessel, 1.5 millimeters in diameter, double the Hounsfield unit compared to the background, and multiple or single. Very good sign. One do see spot sign, but very easy to say because this requires a CT angiography and a contrast, hence a bit of a tedious sign to do. Then we got this sign called the swirl sign. The swirl sign is again a better sign, I would say, more easier to predict. The NCCT in a swirl sign was reliably identified and associated with hematoma expansion. It is proposed that the swirl sign can be included in this stratification of intracerebral hemorrhage and considered for inclusion in clinical trials. Now, this is what a swirl sign looks like, which is quite easy to see, especially if you see in this picture here, that is what a swirl sign is. So you have two signs which you've got to always remember if you want to do hemorrhage, if you want to do stroke. One is the spot sign, difficult to do at times, and one is a swirl sign, very easy to find out that this patient has indication for a hematoma expansion. Now please remember, if you're a critical care person, you should have an ICH score. And you should be able to score your patient. So neurology doesn't mean, you be very specific in everything. You should score your patient. What is the GCS? Give him points. What is the ICH volume? Is there an intraventricular extension? Infratentorial region of the ICH and the age. So this will give you the ICH score. The higher the ICH score, obviously, the higher is the mortality. So the ICH score is a clinical grading that allows for risk stratification of patients presenting with ICH. The 5 categories are independent of 30 days mortality. The use of ICH score could improve standardization of treatment protocols and clinical research study in ICH. This slide, if you just look at this slide, yeah, this is the 30 days mortality, and here is the ICH score. The higher the ICH score, obviously, higher is the mortality. So, our job of treating intracerebral hemorrhage doesn't stop. We should be doing ICH scores, we should be doing these signs, we should be treating the blood pressure. Okay. Now, this is just to just go back. Now, this is just to show you the formula for estimating the volume of the hematoma. Before you show your patient to a surgeon, you should at least know. Now, it's very simple again. Select the CT slide. A is the longest axis in centimeters. B is the longest axis perpendicular. And number of slices and the thickness divided by 2 would give you the hematoma volume. So you got to calculate the hematoma volume also if you want to be more scientific about it. I won't go into this. This is the basic concept which Dr. Shivakumar did talk about. Now, I like showing this slide. And all critical care people, when you approach an ICP, as Dr. Shivakumar rightly said, you've got the CSF, you've got the brain volume, you've got the blood volume, or everything is in a rigid compartment. So if you want to decrease the ICP by blood volume, you've got mannitol, ventricular catheter. If you want to decrease the blood volume, you've got mannitol or hypertonic solution. If you want to play around with the blood volume, you've got mannitol, hyperventilation, hypothermia. So it depends upon which part of these three do you want to target. We had a long discussion on this, but I'll just show you mannitol versus hypertonic saline clinical effects. Now this is important because I just bought this slide, that what is the primary mechanism of mannitol and what is the primary mechanism of a hypertonic solution. Primary mechanisms increase the gradient across the blood-brain barrier. And this also increases the gradient across the blood-brain barrier. Mannitol brings down the rapid reduction of ICP, but immediate reduction of ICP in hypertonic solution. Duration effect is 6 hours and 4 hours. The most important thing in mannitol, as you all know, is you can't overload the kidneys and you can't overload the heart. You can't give large volumes to these patients. And somebody was asking about the doses. These are the dosages of hypertonic solution. I think most of us don't use hypertonic solution, reasons which I don't know. And of course, the excess is by peripheral line. Here you give the excess by a central excess. Hyperventilation I won't talk about. Just last 2 slides about the surgical part. There is not much doubt about the removal of hematomas in the posterior fossa that is cerebellum, and putting a ventriculostomy or a shunt for a third vent or a thalamic hematoma. But there were 2 trials. One was called the Stitch 1 and Stitch 2. And this was the international parallel book trial in 78 countries, in 78 centers in 27 countries, 601 patients compared with early surgical evacuation with 12 hours of randomization plus medical treatment, with medical treatment alone. And what did they find? That the Stitch trial confirmed that early surgery does not increase the rate of disability as 6-1 and might have a small but clinical relevant survival for patients with spontaneous superficial intracerebral hemorrhages without ventricular extension. So Stitch 2 was talking about...
Kindly move the slide.
Sorry, I'm sorry. Stitch 2 was talking about...
Time is also, I think...
Yes, I'm just... Could you take just 2... Stitch 2 was trying to talk about the hematomas which are more superficial, and they found the surgery was little more beneficial over medical treatment, and you can take it the way you want it. And this is, of course, the MISTY trial. MISTY trial was using TPA with the evacuation of the hematoma, and they did find that there was some benefit from this. Now, I end by saying that nothing is possible individually. You can't function individually. You have to function as a team if you want to do good critical care work. And fortunately, in the hospital where I am, we have a wonderful stroke team. We have all got together, put our heads together with our critical care people so that we can decrease the mortality of our patients. I end by saying, ladies and gentlemen, we have launched a YouTube channel on stroke neurology at the Apollo Hospital. Please do go subscribe. You don't have to pay anything. We have loaded some wonderful lectures, and you will love to hear the lectures of Dr. Padma itself there. And it's a channel worth watching. So I request all of you to subscribe for this channel. It will benefit you to learn more neurology. Keep calm and love neurology, and then you'll enjoy neurology. Thank you very much.
Thank you, Dr. Renjen, for such a nice